So hi friends, let us discuss about this NEET PG 2022 Pediatric Recall Questions. So apparently after seeing the questions that we have got from the students, the questions were all doable, and as I could see, most of the questions were from our class notes. So I think students who have attended our classes, who have seen the eGurukul app, gone through it, and especially the pediatric content, should have been able to answer most of the pediatric questions. So we'll be discussing those questions, and we'll be seeing what answers to those questions were. Again, a disclaimer is that these are the questions that have been told to us by the students as recalled by them. So obviously, if there are certain differences in the language, it might change the answer to the question. But as of now, what I feel is, based upon these questions that we have got, these are almost quite accurate questions, and we can rely on them. And I'll be answering those questions and seeing what the explanations to those answers are. So let us come to the first question that was asked this year in NEET PG 2022 pediatric question. And this question was a question on infantile spasms. So I think students who had attended my classes, who have gone through the eGurukul app pediatric portion, are very familiar with this disorder. This is a epileptic spasm that is seen primarily in infants. So the question was, a 11-month-old child had recurrent jerky movements of the limbs. The child developed regression of the milestones, and there was an EEG pattern which is suggesting hips arrhythmia. So it's a very classical triad that I tell in my classes also. In fact, this is the triad that I normally tell in my classes. And this triad is a triad of infantile spasms or the West syndrome. So this is a typical triad of infantile spasms or the West syndrome. So in my classes, I've told in the past also in my classes that West syndrome is a disorder that is primarily seen in children between 2 to 12 months of age, although the age groups might vary a little, but usually in most children, that is infants between 2 to 12 months of age, we have the onset of these epileptic spasms. So the triad of epileptic spasms along with psychomotor retardation and a developmental retardation. So developmental retardation in these children is often associated with psychomotor retardation as well, which often confers poor prognosis to many of these children. And when I say developmental retardation, that means the milestone regression is seen in these cases, which is actually written in the history of this child also. And along with this is a very characteristic EEG pattern, which is known as hips arrhythmia. In fact, I've shown hips arrhythmia pattern in my classes also, and in my eGurukul pediatric app also. This is high voltage, slow wave, chaotic background, multifocal spikes, and this characteristic chaotic background, whenever associated with epileptic spasms and developmental retardation, this chaotic background on EEG usually very strongly indicates that the child has infantile spasms or the West syndrome. So this is what we have discussed in our eGurukul app. So I've discussed, this is a screenshot of infantile spasms of West syndrome that we have discussed in our eGurukul app also. In my classes also, when I have taken classes, I have discussed about this disorder because this is likely to be a very commonly asked disorder in the exams. It is seen as a combination of epileptic spasms, psychomotor retardation, which is often associated with developmental retardation, and a characteristic EEG pattern. And you are seeing the EEG pattern, which is known as hips arrhythmia. Now, this pattern of EEG is very characteristic, and whenever you diagnose a child to have infantile spasms, you would start a treatment for infantile spasms. The drug of choice for infantile spasms, as I've repeatedly told in my classes, the drug of choice for infantile spasms is ACTH, Prednisolone can be used as a cheaper alternative to ACTH, but the drug of choice has always remained ACTH. In fact, injectable ACTH given twice daily, the dose 150 units per meter square given twice daily, so it's divided into twice daily doses given for a period of 2 weeks, and then subsequently the dose is then down titrated, and this dose is then down titrated over the next 2 weeks. So a total of around 4 weeks of treatment with ACTH. That's the drug of choice for the treatment of infantile spasms. Prednisolone can be used as a cheaper alternative, but that's not widely recommended because you have to use high dose prednisolone as a cheaper alternative to ACTH. So the drug of choice for infantile spasms is always ACTH. That is why the drug that they asked here, which should be used here, is ACTH. Now, students have often asked me the reason why ACTH is used as an anti-epileptic drug in these cases. And to be very frank, the precise mechanism of action of ACTH in these cases is not known. There have been some suggestions that various stressful factors are known to stimulate the release of corticotropin releasing hormone in the brain in children with infantile spasms. And this increase in the corticotropin releasing hormones by those stressful factors is known to increase the neuroexcitability, and this neuroexcitability increase may lead to the development of seizures. So that is probably one of the mechanisms that has been suggested for the development of infantile spasms, and that is the reason why ACTH and even prednisolone can be used in the treatment. Both of them are known to reduce the levels of corticotropin releasing hormone. Plus, it is believed that ACTH by its own direct action also on the brain can stimulate the release of glucocorticoids and thereby decrease neuronal excitability. So that is probably the mechanism by which ACTH functions, but as I said, this is a probable mechanism of action. Vigabatrin can be suggested as the drug of choice, and this again I have told in my classes. Vigabatrin can be suggested as a drug of choice when infantile spasms are associated with a neurocutaneous disorder, which is tuberous sclerosis. But since we do not have Vigabatrin as a choice in this question, the answer very clearly is ACTH. So I think this was a pretty simple question, and the answer to this is ACTH. Let us now come to the next question, which is question number 2, which was again discussed in our class. This question was a part of NEET PG 2022 again. Again, the language might differ because this is what we get from the recalled questions by the students. The question according to the students was of a young child who was brought by his mother complaining of multiple episodes of loose stools along with the presence of drowsiness and lethargy. Now the skin pinch was going back very slowly. Now this is very important. Skin pinch is going back very slowly, and there is presence of both drowsiness and lethargy in the child. So one thing is for sure, this child is definitely in a state of dehydration. So the segregation is into no dehydration, some dehydration, severe dehydration. This child definitely by all means is in a state of dehydration. So no dehydration is ruled out. The question is this child in a case of some dehydration or is this child in a case of severe dehydration? Again, in my classes and in the eGurukul notes, which is again there you can see the snapshot of the eGurukul notes, where I have discussed about dehydration in children. And we have very clearly outlined the markers of severe dehydration in a child, which are different from the markers of some dehydration in a child. You can see the difference between them. Now, some dehydration is what in the past we used to call as moderate dehydration. And some dehydration is characterized by a child being more restless and irritable in comparison to severe dehydration child who is more of lethargic or an unconscious child. And in our case, the patient is lethargic. The patient is not irritable. The patient is lethargic, drowsy. Second, the child is not able to drink water or liquids if the child is in severe dehydration. On the other hand, a child who is in some dehydration often will drink water very eagerly. So that's another very important difference between a some dehydration and severe dehydration. In some dehydration, the child, when given water, will drink it very eagerly because the child is actually thirsty. Dehydration will trigger a thirst mechanism that will increase the water intake by the child. However, in the case of severe dehydration, despite the fact that the child is severely dehydrated, the child is either not able to drink liquids or drinks liquids or water very poorly. Then oral mucosa and eyes are sunken and dry in both cases. Then skin pinch goes back slowly in a case of some dehydration, while it goes back very slowly in a case of severe dehydration. I have stressed about this fact. Goes back very slowly. Although this difference goes back slowly and goes back very slowly is arbitrary. But roughly they say that if on pinching a fold of skin, it takes more than 2 seconds to go back to its original position, then we say that the skin pinch goes back very slowly. And this again indicates that the child is in a severe dehydration. So again, if we go back to our question and we see our question, the question clearly says that the child is having multiple episodes of diarrhea, which increases the chance of dehydration. The child is drowsy or lethargic, is not irritable or restless, which again rules out some dehydration. And the child's skin pinch goes back very slowly, which again or in by all accounts indicates that the child is in a severe dehydration and not in a no dehydration or a some dehydration. The treatment of this child will be by giving IV fluids, and usually normal saline or ringer lactate can be used. Ringer lactate is usually the drug of choice or the fluid of choice. Depending upon the age of the child, if the child is less than 1 year, 30 ml per kg of IV fluid is to be given over 1 hour, followed by 70 ml per kg of IV fluid over 5 hours. And in case the child is more than 1 year, then 30 ml per kg of IV fluid is given over half an hour, followed by 70 ml per kg of IV fluid over 2.5 hours. So I think again, students should have been able to answer this question very easily. This is clearly a case of severe dehydration. Coming to the third question of NEET PG 2022 pediatric question. The question was of a child who is a 7-year-old male child who presented with palpable purpuras over the lower limbs and the buttocks, complaints of arthralgias, abdominal pains, and a previous history of an upper respiratory tract infection. So a child who's presenting with purpuras, and that too on the dependent portions of the body, including the lower limbs and the buttocks, is presenting with arthralgias and abdominal pains, and I think this question has been repeated multiple times in the past. This is a very likely scenario of a child having a enoch purpura. Now this enoch purpura is a small vessel vasculitis of childhood. It's a small vessel vasculitis of childhood. It is often associated with the leukocytoclastic vasculitis, where there is deposition of IgA in the small blood vessels of the skin, of the gastrointestinal tract. So that is why, because of the deposition of IgA in the small blood vessels, it is sometimes also called as an IgA vasculitis. So the typical triad of the symptoms that are present in these children are abdominal pain, arthralgias, and rashes. There has been a clear evidence that previously there are indications that the child has an upper respiratory tract infection, either can be caused by streptococcus or can be caused by Staph aureus. But there is quite likelihood of this disorder following a previous streptococcal or a staphylococcal respiratory tract infection, which was present in our case also. Now, many people believe that this is actually one of the most common vasculitis of childhood, and there has been always a debate about whether Kawasaki's disease or enoch purpura is the most common vasculitis of childhood. Both of them are quite common. Kawasaki's disease is more commonly a medium vessel vasculitis of childhood with a propensity to affect the coronary arteries, while enoch purpura is usually a disorder that affects the small blood vessels, including the glomerular capillaries. That's the reason why kidneys can get involved in these cases. But the classical presentation is always of purpuras in the dependent portions of the body, palpable purpuras, abdominal pains and arthralgias. Now, most of these cases who have enoch and purpura, they actually are known to have a self-limiting illness. So in many cases, actually the treatment is not required. The disorder usually resolves on its own in about 7 to 10 days time. However, glucocorticoids can be used in these cases. Glucocorticoids can be used in these cases in case there are life-threatening complications, or in case there is even involvement of abdominal symptoms, which indicates that there is probably a mesenteric vasculitis that is happening in these cases. In those cases, glucocorticoids can be used. So although it's a self-limiting illness, glucocorticoids can be used especially for life-threatening complications and also for conditions in which there is abdominal involvement. Yes, in cases where renal involvement occurs, in those cases you might like to add immunosuppressive agents such as azathioprine or even a cyclophosphamide. About 30% to 50% cases renal involvement does occur. But because the renal involvement has not occurred in this case, we will not like to think about azathioprine or cyclophosphamide or even a cyclosporin. So I would think of a glucocorticoid as the first line drug for the treatment of enoch and purpura. But as I told you, majority of those cases will resolve on their own in 7 to 10 days time and usually may not require any treatment. But again, as I have been saying again and again, it all depends upon what exactly the question was and what the choices were. So in case the question is slightly different or the choices are slightly different, that may provide another answer or may be a reason for giving another answer to the same question. But going by this question, this is clearly a case of enoch and purpura, which should be managed by giving glucocorticoids. 30 to 50% of children with the enoch and purpura have renal involvement, and those cases then in addition need to be treated with immunosuppressive agents. In some very rare cases, intravenous immunoglobulins have been used, but that is not usually the first line agents. First line agents for the treatment of life-threatening complications in HSP, enoch and purpura, are glucocorticoids. And I've discussed about this in my eGurukul notes also. So you can see enoch and purpura, I've discussed in detail about the fact that it is associated with palpable purpuras, it is associated with arthritis and arthralgias, it is associated with abdominal pains, and then it is also associated with the development of renal involvement, which may occur in about 30% to 50% cases, usually by 3 to 6 months after the onset of illness. And as I have said, steroids, particularly those corticosteroids with glucocorticoid effects, such as prednisolone, may be used in the management, but only usually in cases where there are life-threatening complications. So this again has been discussed in my classes, and students who have attended my classes or have gone through the eGurukul app pediatric version should have been able to answer this question. Question number 4 was a question which is a question on rheumatic fever. So the question is, an 11-year-old girl presented with sore throat and streptococcal infection which has occurred 20 days ago, followed by fever, arthralgias and an elevated ESR. So there is a history of sore throat and streptococcal infection which has occurred about 20 days ago. Again, the duration was not very clear among the students. Some said around 20 days, some say around 25 days, some said 40 days also. But most cases of rheumatic fever, they follow a streptococcal infection and normally follow a streptococcal acute episode by about 10 to 21 days after the streptococcal throat infection. And classically, most cases of rheumatic fever occur in children who are between 5 to 15 years of age. And we know the classical major manifestations of rheumatic fever, which includes carditis, arthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. Now, Most of these are associated with an increase in the acute phase reactants, including an increase in the ESR also, an increase in the CRP also. The definitive diagnosis requires evidence of previous streptococcal infection. Presence of ASLO titers, increased ASLO titers can be present in about 80 to 85% cases of rheumatic fever. But if you do multi-antibody testing, such as ASLO titers, anti-DNase B titers, and anti-hyaluronidase titers, then you are likely to detect almost around 90 to 95% cases of rheumatic fever. So anti-hyaluronidase, anti-DNase, and ASLO titers, when combined antibody testing is done, then they can be seen in almost around 95% cases. They are found to be raised. Now, the question is on the correct option for prophylaxis. Now, there has been a lot of discrepancy regarding this fact. And again, in my eGurukul app, I mentioned about the duration and prophylaxis very clearly. Although there has been discrepancy among different books about the prophylaxis part. See, the treatment part, I will not go into the details about the treatment part of acute rheumatic fever. Acute rheumatic fever, the treatment part usually is first by giving oral penicillin or oral erythromycin treatment, which is given for a period of 10 days. The idea is that we have to eradicate the streptococcal carriage. Then there is also evidence of the role of anti-inflammatory therapy such as salicylates or corticosteroids. Salicylates particularly are very useful for the treatment of polyarthritis, and they are also very important or useful for the treatment of carditis if carditis is not associated with cardiomegaly or heart failure. So as long as the carditis which occurs in rheumatic fever is not associated with cardiomegaly or heart failure, you can use salicylates in the treatment. However, corticosteroids can be used in the treatment, or rather I should say should be used in the treatment whenever there is evidence of carditis associated either with a cardiomegaly or with a heart failure or associated with both. So 12 weeks treatment of steroids may be necessary in such cases. Now coming to the prophylaxis part. Now to prevent a recurrence of rheumatic fever episode and its adverse effects, particularly on the heart, which ultimately may lead to the development of rheumatic heart disease, there is evidence that you have to give prophylaxis. In places where the rheumatic fever may not be very common, that prophylaxis needs to be given every 4 weeks. But in cases where this disorder is quite common, you need to give it every 3 weeks. The dose of injection benzathine penicillin, and by the way, injection benzathine penicillin single dose can be used in the treatment also in case oral penicillin or erythromycin is not available. A single dose of benzathine penicillin can be good enough. Now coming to the prophylaxis part. For the prophylaxis part, this benzathine penicillin needs to be given in a dose of every 3 weeks and in a dose of 1.2 million units in the case the child is more than 60 pounds. And in case the child is less than 60 pounds, then you usually give half the dose. So 6 lakh units and 12 lakh units. 6 lakh units less than 60 pounds, 12 lakh units more than 60 pounds. Or normally they say less than 27 kgs, more than 27 kgs. Now, the discrepancy is how, there is no discrepancy about how frequently you give it. That's every 3 to 4 weeks, as I told you. But how long you give it, there is a lot of discrepancy among it. The Indian textbooks, such as OP Ghai, normally says that in case there is no evidence of carditis, this benzathine penicillin should be given either till 5 years for a 5 years duration, or should be given till 18 years of age, whichever is longer. In Nelson's textbook of pediatrics, there is a little difference. They say it should be given for 5 years duration or till 21 years of age, whichever is longer. So this is what is given in Nelson's textbook of pediatrics. But I personally feel, and this is what I've taught in my classes also, when you are when you confront such type of discrepancies in different books, I personally feel that in many cases, it's the Indian textbooks, and OPGAI is a standard textbook. So Indian textbooks should give you quite reliable evidence of literature. And therefore, in my classes, I have said that for no carditis, you should give injection benzyl penicillin for either 5 years duration or till 18 years of age, whichever is longer. But in Nelson's textbook, as I told you, it's written for 5 years duration or till 21 years of age, whichever is longer. Then, for children who have carditis, and when I say carditis, that means a carditis which is a mild to moderate carditis and without a rheumatic heart disease, without evidence of rheumatic heart disease, you should give this prophylaxis for 10 years duration and till 21 years of age, whichever is longer. But again, in Nelson's textbook of pediatrics and in some other books, the mention is of giving this for 10 years duration or till 21 years of age, 25 years of age, whichever is longer. So there is a little discrepancy in different books. What I have told usually in my classes is this: no carditis, you give it for 5 years duration or till 18 years of age, whichever is longer. In carditis, but without an established rheumatic heart disease, we normally say mild to moderate carditis, or a carditis without a established rheumatic heart disease, you give it for 10 years duration or till 21 years of age, whichever is longer. Although in many books they have mentioned for 10 years duration or till 25 years of age, whichever is longer. And in case there is evidence of severe carditis, where for example valvular heart surgeries were required, or even in cases where there is an established rheumatic heart disease, in those cases you will then give it for a longer period of time. So the longer period of time normally they mention is till 10 years, for 10 years duration or till 40 years of age. And sometimes they might recommend it lifelong, although obviously lifelong prophylaxis is something which many people do not agree to. But at least they say for severe carditis or when there is already an established rheumatic heart disease, it's better to give it till 40 years of age. So what I'm trying to tell is that how long you will give prophylaxis with injection benzyl penicillin every 3 weeks. The total duration of prophylaxis will depend upon whether the child has no carditis or has carditis which is mild to moderate usually, or a carditis but does not have a rheumatic heart disease, without a rheumatic heart disease. And the third scenario is where there is a severe carditis, say where a valvular heart surgeries were required, or there is an established rheumatic heart disease. So in all these different scenarios, different durations of prophylaxis is recommended. Now in our case, it was clearly written that there is no evidence of carditis or any evidence of a residual heart disease, which clearly means the child should be given duration of prophylaxis according to the first mentioned category. And the first mentioned category is usually 5 years duration or till 18 years of age, whichever is longer. So as I'm saying, I still again do not know whether these were exactly the choices or this was exactly the language of the question. But in case the language of the question was different or the choices were different, that will change the answer to the question, or probably may change the complete question also. So we are strictly going by what we have been able to recollect from the students, and anyone who has given such highly stressful exams, it's understandable that when they come out, They will take time to be able to recall those questions, and when they do recall, it's very, very understandable that probably many times the exact lines may not be recalled. And when you do not recall the exact lines, their lines may be different, then the answer may easily change. Then there is another question, which was question number 5, which was a picture based question, an image based question. This question was of a child having a typical picture here, and I think, although I have not discussed this in my class, but I think it's very clearly understandable what this disorder is. See, a gastroschisis and omphalocele, they are abdominal wall defects. So gastroschisis is actually an abdominal wall defect, which is actually more of a paraumbilical abdominal wall defect, where the abdominal contents, including the intestines, are herniating out and they are not covered by any peritoneal sac. So they are paraumbilical defects. Omphalocele, on the other hand, are more of central midline umbilical defects. And here the structures that are herniating out, such as the intestines, they are actually covered by a peritoneal sac. And this does not appear to be a case of either a gastroschisis or a omphalocele. The typical position of the defect, that is the position above the suprapubic area, plus the positioning of the umbilicus, which appears according to me to have been pushed downward, and you're very clearly seeing a mucosa which is actually eviscerated or coming out or everted. That clearly means that this is most likely a bladder extrophy. Now this is a very rare congenital umbilical urinary bladder disorder. I'm sorry, not umbilical, urinary bladder disorder, and its incidence is actually very rare. I probably feel it's I've read it somewhere, it's around 1 in 40,000 cases or 1 in 50,000 cases, which makes it very rare urinary bladder disorder. As the name suggests, a bladder extrophy. So what happens is that the posterior visceral wall of the bladder is actually everted, coming out, and it can come out to different degrees of severity. So this disorder may be of different grades of severity, and it can often be associated with an extrophy of the cloaca also, and can be associated many times with epispadias also. And usually what happens in these cases is that the surgery that needs to be done for a bladder extrophy cannot be done in one single step. So over a period of time, it needs to be done in several steps. The diagnosis many times can be made by an antenatal ultrasound only. The bladder will not be seen filling. And after the child's birth, then the child will have this typical type of picture, which can actually suggest to the presence of a bladder extrophy. And in these cases, serial surgeries are required to correct this disorder. So this definitely does not appear to be gastroschisis or omphalocele. Both of them are abdominal wall defects. This does not appear to be an abdominal wall defect. Omphalocele can be associated with Beckwith-Beaman syndrome and many trisomies like trisomy 13, trisomy 18, trisomy 21. They're all associated with omphalocele. Coming to question number 6. Again, this was something which many students said, sir, this question was not there. Some students said, sir, this question was there. So I put this question, and in case there is any change in the question, please do tell me about the change in the question in the comments box. So they asked which of these disorders is an autosomal recessive disorder. In fact, later on they have a question on osteogenesis imperfecta also. Now disorders like osteogenesis imperfecta, Treacher's-Collins syndrome, achondroplasia, cystic fibrosis, they all are disorders which have a strong genetic basis. And most of these disorders, including osteogenesis imperfecta, Treacher-Collins syndrome, and achondroplasia, are predominantly autosomal dominant. Although we do have some autosomal recessive rare varieties of osteogenesis imperfecta also, and of Treacher-Collins syndrome also, rare varieties. But in case it's a single answer question, then the best answer should be cystic fibrosis, which again in my classes I've told clearly it's an autosomal recessive disorder associated with a mutation in the CFTR gene. Osteogenesis imperfecta, we'll discuss a little later, is more of a connective tissue disorder in which the synthesis and the processing of collagen 1 is impaired. Treacher-Collins syndrome is more of a disorder which is associated with the predominantly facial dysmorphisms, skeletal dysplasias, facial dysmorphisms. Down slanting palpebral fissures often associated with malar hyperplasias, mandibular hyperplasias, microtia. So these are the features that are often seen in Treacher-Collins syndrome. Achondroplasia, we have discussed about this topic in, or not about this exact topic, but we have discussed about, made a mention of achondroplasia in our short stature topic. So when I taught short statures in my classes, I've already told that short statures, particularly the pathological short statures, can be proportionates and disproportionates. And achondroplasia is an example of a disproportionate short stature. It's a skeletal dysplasia which is associated with a mutation in the FGFR3 fibroblast growth factor receptor 3 gene. And achondroplasia is again a predominantly autosomal dominant disorder. So the only disorder that appears to be an autosomal recessive disorder very clearly is cystic fibrosis, which is associated with the dryness of the secretions in different glandular ducts of the body. So pancreatic secretions dry, airway mucosa becomes dry, the bile becomes dry, intestinal obstructions because of dry intestinal secretions. In newborns it presents with meconium ileus, it can present with rectal prolapse. So all of these can be manifestations of cystic fibrosis, which is an autosomal recessive disorder. So that answers question number 6 now. Question number 7, which again is a question that was asked in this NEET PG 2022, and I've discussed about this in my class. Mother was worried that her child did not pass urine on postnatal day 1. So now the child is 24 hours. And despite being a 24-hour child, the child has not passed urine. And in my app, I have clearly mentioned that the child after birth should pass urine within 48 hours and the child should be able to pass meconium by 24 hours. So you start to get more worried if a newborn has not passed meconium even after 24 hours, or a newborn has not passed urine even by 48 hours. So if a newborn has not passed urine by 24 hours, it's something which is not very, something which is not very worrying for a doctor. It's something which should not concern a doctor, a pediatrician. I would be more concerned if a newborn has not passed urine for 48 hours. That's when I start thinking of an acute kidney injury. So suppose a newborn is delivered and a newborn has not passed urine for 48 hours or more. That's the time when I start thinking of something like oligoanuria. The definition of oligoanuria in a newborn is when the child has not passed even a drop of urine for 48 hours, or the urine passed is less than 1 ml per kg per hour, which is considerably low urine output in 48 hours. That's the time you start thinking of acute kidney injury. Although there are some cases of acute kidney injury where oliguria may not be present. So even a serum creatinine in a newborn which rises to more than 1.5 milligrams per deciliter can again be an indication of the presence of oligoanurias. So 24 hours is something which I will not worry about. 48 hours is something which I will worry about. Child has not passed urine for 48 hours. I will shift the child then to an ICU. I will also give a fluid challenge in this newborn. About 10 to 20 ml per kg of normal saline can be pushed over 1 hour. And in case the child's urine output increases to more than 1 ml per kg per hour after giving this fluid challenge, that probably means the child was in a pre-renal AKI, pre-renal type of or pre-azotemic type of acute kidney injury. There is no role of furosemide or no role of dopamine in such children. So because this is a child who has not passed urine for 24 hours, one day, I think the only reason could have been that probably in the first 24 hours, many children take insufficient amount of breast milk because they are usually getting adapted to sucking and swallowing. And that's the reason why I would only recommend the mother to continue breastfeeding and observe further. And in case the child does not pass urine even by 48 hours, that is the time when I start becoming more worried. So if a child has not passed urine by day 1, answer would be continue breastfeeding and just observe the child. There is no point of starting formula milk, no point of starting IV fluids right now. Yes, as I told you, IV normal saline would come into effect in the management part when the child has not passed urine for 48 hours or more. And coming to question number 8. Now question number 8, again some students said the question was on a fetus with multiple long bone fractures, while some said it was on a newborn. Even if it is a fetus with multiple long bone fractures, I think this is a pretty simple answer, and the answer is osteogenesis imperfecta. It's a connective tissue disorder. Osteogenesis imperfecta is a connective tissue disorder which is associated, it's a connective tissue disorder which is associated with abnormality in the synthesis and in the processing of type 1 collagen. So these children can present with multiple fractures, pathological fractures, which can start from the fetal life also. So long bone fractures, blue sclera, short statures, even deafness in later age, all of them can be features of osteogenesis imperfecta, and it can be of varying severity. For example, there is a type 1 osteogenesis imperfecta which actually may not be very damaging, it may not be very deforming, but type 2 is the one which is more likely to be perinatal lethal or perinatal fractures associated in the fetus with type 2 variety. Type 3 may be progressively deforming, type 4 may be moderately deforming, and type 5 may be associated with callus hypertrophies. And most of these common types of osteogenesis imperfecta, type 1 to type 5, are autosomal dominant varieties, although there are some other less common types of osteogenesis imperfecta also, which may be inherited in an autosomal recessive fashion probably. But conventionally osteogenesis imperfecta has always been considered as an autosomal dominant disorder. And these type of long bone fractures is not how congenital hypothyroidism, cretinism present, nor this is how achondroplasias or Marfan syndrome presents. So I think answer to question number 8 was pretty simple. It was an osteogenesis imperfecta. Coming to question number 9. Now question number 9 again is a question which is more of a pediatric surgery question. But since this again involves a child, I will just take a minute to discuss about this question. So this was a question of an 11-month-old child who presents with a Courant jelly stools, then a right lumbar mass and recurrent abdominal pains. And you can very clearly see a sign which is referred to as the claw sign. It's referred to as the claw sign, and usually the sign is seen on a barium enema. And this very clearly indicates that the child most likely has an Intussusception. In fact, if you actually see the child's age also, and I mentioned in my eGurukul notes, this is again eGurukul notes where I've made a mention of Intussusception, and I've mentioned that it's the most common cause of abdominal pain, particularly acute abdominal pain, which occurs in children between 3 months to 6 years. And our patient was 11 months of age. So what happens in an intussusception is that the proximal part of the intestine, through its peristaltic activity, it tries to invaginate into the distal part of the intestine, usually the small intestine into the large intestine, which creates a state of intestinal obstruction and a very severe acute abdominal pain. Often it is associated with a sausage-shaped abdominal mass, and it is often associated with Courant jelly stools. Emptiness of the right iliac fossa in such cases may often present with a sign which is called as the dance sign. It's one of the most common causes of an acute abdominal pain in children between 3 months to 6 years of age. Although many children present between 9 months to 2 years, that's the highest age incidence when intussusception is known to present. But overall, the incident can occur anytime between 3 months to 6 years. It can be seen less commonly in elderlies or in adults also. More common it is seen in children. And in children, it can often follow either a viral gastroenteritis episode. It can also be considered sometimes as a problem associated with the use of rotavirus vaccine. In fact, the first rotavirus vaccine which was brought in the market had to be withdrawn because of the risk of intussusception associated with that vaccine. And this intussusception remains one of the problem that should be suspected sometimes in rotavirus vaccines, although the current rotavirus vaccines are largely very, very safe vaccines. And as far as I know, the risk of intussusception with those vaccines is minimum. But at the same time, you cannot totally neglect the incidence. It is very low, negligible, but at the same time present or associated sometimes with these vaccines. In adults, it has been associated with malignancies, intussusception, but in children, it is commonly associated with gastroenteritis episodes, as can be seen by Peyer's patch hypertrophies that are present in these cases. Most of these children are treated by enemas, and in case that does not work, then obviously surgeries may be required. But the surgeons will tell you this much better than us. I just needed to tell you about a few important things about this, which I've all told you. The last question which I will discuss, again, it's quite likely the biochemistry sir has discussed about this, but because this again involves a child, and I've discussed this in my classes as well in the metabolic syndrome chapter, I've discussed about this in my eGurukul metabolic syndrome chapter. I've clearly discussed about this topic. So I've mentioned this question here. So the question was of a child who presents with exercise fatigue. Again, the exact language of the question I'm not very sure. But the child presents with exercise fatigue, and the students say there was a feature suggestive of McArdle's disease, the type Y glycogen storage disorder. So there is an abnormal storage of glycogen here. Glycogen storage disorders, and can occur because of multiple enzyme deficiencies. And I've told in my classes that glycogen storage disorders can be glycogen storage disorders primarily affecting the liver, and glycogen storage disorders primarily affecting the muscles. And this is a part of my eGurukul snapshot. So very clearly it is written that whenever there are glycogen storage disorders which primarily affect the muscles, like the type 5 glycogen storage disorder, which is McArdle's disease, even type 7, but type 5 is the classical case of McArdle's disease, which is a pure muscle associated glycogen storage disorder. There will be features of hypotonia, features of skeletal muscle weakness, myopathies, muscle fatigues, which is being experienced by our patient. A child who is having a liver associated glycogen storage disorder are more likely to present with hypoglycemic episodes, hepatomegaly, liver failures. So we have different types of glycogen storage disorders, and the glycogen storage disorder type 5 is always considered as the primary type of muscle glycogen storage disorder. And because in our patient there is muscle fatigue after exercises, So it cannot be a liver glycogen storage disorder. It has to be a muscle glycogen storage disorder. And this usually is because of the deficiency of the enzyme muscle phosphorylase. Although the phosphorylase of the liver, when it is deficient, can lead to glycogen storage disorder type 6, which is also known as the Her's disease. But the muscle phosphorylase activity is diminished in children who have McArdle's disease. And because in our patient we had a child who is having exercise fatigue, so muscles are primarily affected. Therefore, the best answer here should be enzyme which is likely to be deficient is phosphorylase, and particularly the muscle phosphorylase deficiency. Glucose 6 phosphatase deficiency is more commonly associated with type 1 glycogen storage disorder, which is also known as the von Gerk's disease. And the lysosomal glucosidase deficiency is often associated with glycogen storage disorder type 2, which is often considered as a part of a lysosomal storage disorder as well. So anyway, so the answer here according to me should have been phosphorylase, and much better probably would have been told to you or described to you by your biochemistry faculties. So this is all I could get from the students. Thank you very much. I hope you have understood these questions and you have correlated these questions from the questions asked in the exams. In case there were any changes, you can suggest to me those changes in the language of the questions. In case there were any options, as I am again and again saying, all the questions that have been mentioned are primarily questions that have been taken as recall. So the language might be different, and in case the language is different or the options are different, it changes the answer completely. So I am available on Telegram also. I have a Telegram group also. You can join that group also. I can send the invite link also for joining the Telegram link. We can have pediatric discussions on that link also, that group also. So you are most welcome to join that link also. And I'm available on Telegram also in case there are any changes that you want to suggest in the questions language, in the options, or there are additional questions you want to tell me and want me to discuss. Please inform me about those questions or those changes on my Telegram link. So thank you very much and goodbye.